We are live, please.
Welcome everybody to a joint Journal Club meeting of MOS and BOA Season 4 and yet another Journal Club meeting. Here we have a stalwart glaucoma specialist internationally and nationally today discussing on association between statin use and glaucoma, and it will be a great talk and a great discussion. And without much ado, I ask the President MOS to open the meeting. Shiri sir, just
thank you, Vaishal. Thank you. I'm really honored to welcome you all for today's important meeting on the different topic, that is relation of statin with the glaucoma. And today we are fortunate to have esteemed experts, Dr. Ramulu and Dr. Ronnie George sir, as our experts. Will share their knowledge and insights about benefits and challenges associated with the same. I would like to express my gratitude to all speakers for their time and expertise, and to all for joining the meeting. And with the Sabyasachi as a moderator, it is going to be a great academic feast for everyone. I'm sure for that. Over to you.
Another luminary today has joined us, Professor Dr. T.P. Lahane, sir, and I would ask him to bless us and open this meeting, the Journal Club meeting, sir. Lahane, sir.
Thank you, Vaishal. Thank you very much. I really welcome both the Ramulu and Roni, the really big people in the glaucoma. Sabyasachi is there, and this one, everybody, experts, the series who is taking PUs and series, they are taking keen interest in all these activities. I really appreciate their work. And all these young people have joined in this conference. And as you know, the Sabyasachi is the person who is, I think, very research oriented, and I can say he has a just excellent vision towards the ophthalmology. So I think those people who are attending seminar or later on they are going to visit, they will be very happy for this seminar. And I think my best wishes. And glaucoma, I think it is a very difficult disease. And in India, there is no, you can say, the health checkup regularly. And so the patient comes very late, one eye blind and other eye is having the tubular vision. And that time they expect that we should treat them. So this Vaishal, I think he is very regularly doing this activity from so many years. So I appreciate the efforts of Vaishal also, and the speakers and all panelists. I wish them best of luck. Please go ahead and have an excellent this seminar. Thank you very much.
Thank you so much, sir. And without further ado, I ask Dr. Sabyasachi to moderate the session and take it over further.
Thank you so much, Dr. Vaishal, and very good evening, all of you who are live with us, and also who will be joining us slightly later on. And so we are going to discuss a very interesting paper on do statins actually cause glaucoma, or are statins protective in glaucoma? And so common wisdom would say anything that reduces lipid levels would actually protect us from glaucoma and all of these vascular disorders. But then, as you will see, this paper has a little contrary findings, and then we'll discuss this a little bit in detail. So we have a very esteemed panel with us, and I would take a couple of minutes to introduce them. So Dr. Pradeep Ramalu, he is my mentor, and I am what I am because of the time I spent with him at Wilmara Institute about a decade ago. And it's been that long, but then I've carried all that information with me. So he currently is the director of the glaucoma services at Wilmara Institute at Johns Hopkins Hospital, and he's doing a terrific job of bringing up the department to leaps and bounds. His research not only looks at clinical aspects of glaucoma, but also very interestingly looks at the other morbidities that glaucoma could cause, including problems like falls and mobility and all of those. So you should definitely try and look at some of the research that he's doing, and it is really cutting edge. So welcome, Dr. Pradeep Ramalu, and thank you so much for sparing time during your busy OPD day today. So very welcome. So I also would like to welcome Dr. Ronnie George, who is the Director of Glaucoma Service at Shankar Netralaya, and seen a lot of fellows in India who practice glaucoma perhaps have gone through his training program. So he did his MS from CMC Vellore, and he is one of the leading authorities on especially the prevalence and epidemiology of glaucoma, and he has headed the Chennai glaucoma study, which has thrown in a lot of information about different aspects of glaucoma in rural and urban populations. So so we are very happy to have both Professor Ramalu and Professor Ronnie George with us. So I would like to now invite Dr. Muskan Mangal, who is a second-year DNB resident at NIO, National Institute of Ophthalmology, Pune, where I head the research department, and she's one of the most, one of the brightest residents that I am interacting with currently. So I would like Muskan to share her screen and take us through the publication.
First of all, before sharing my screen, I am going to share it. Just I want to thank you all, because so early in my DNB, I never thought that I would get the opportunity to present something like this in front of like such esteemed people. So thank you for the opportunity, sir. Thank you so much. I'll start sharing my screen. Just a minute.
You will see a share screen option at the bottom, and we can see your screen now. Please go ahead, please.
Yeah, so I hope you all are able to see the presentation.
Yes, go on full screen mode and.
Yes. So, as Sabyasachi sir already told all of you, today we are going to discuss about this study, that is there any association between the statin use and glaucoma. And this study was done by an All of Us research program, which was published in this Ophthalmology Glaucoma 2024 edition. So first of all, the introduction that I don't need to tell all of you, but glaucoma is a group of progressive optic neuropathy which damages the optic nerve, and it is usually associated with elevated intraocular pressure.
I will just interrupt you because you need to go into the full screen mode because we don't see your slides moving. Could you go into the full screen mode? Yeah.
Are you able to see now?
No, your screen is not yet in full screen mode. So just and make it.
Go to slideshow. Go to slideshow first.
1 minute, sir.
Bottom right, you will see that's the slideshow, right? The full screen.
1 minute. I'll stop sharing. I'll start sharing again. Entire screen.
Yeah.
Yeah.
Share your entire screen.
That's right.
Is it visible now?
Yeah. Go into slideshow. Yeah.
That's right.
Now it's
Yes,
okay,
yes.
visible.
Go ahead. Yeah, introduction.
So now we were on the introduction part. So as I already told you, glaucoma is related to the optic nerve damage and
Dr.
associated
Muskan,
with
small request. Can you just hide that the dialog box which is there in front? Just you hide. Right inside.
Yeah, okay.
Then it has got a hide button. Yes.
Yes. Okay. Sir. So it is one of the leading causes of the irreversible blindness worldwide, and it does lead to gradual loss of peripheral vision. So actually, glaucoma is something which sneaks very slowly into patient. So because it affects the peripheral vision first, the patient is not like he does not come to us very early stage and usually comes very late. Now something about statins. So statin is one of the one of the first line treatments used in lowering the LDL cholesterol levels, and before this study it was not talked about a lot. Usually statins, when we talk about cholesterol medications or something, they usually associated with cardiovascular diseases and things like that, but its direct association with something like glaucoma, at least for me, it was very first, like I studied it very first time. So statins have been suggested to increase retinal and choroidal blood flow, protect retinal
Sir, I think she's internet connection. You'll have to just call her up.
Yeah, let me just see if. Sometimes you don't even realize that that's happening.
Yeah, that is.
Yeah. I think they are trying to get her back. We'll just give it maybe a minute or so. I also do actually have the slides and I can take you through the presentation if she is not joining in a couple of minutes.
We can play a presentation keeping her video off, so that would probably help with
maybe
streaming.
Right. Muskan, if you're back online, you can share and then switch off your video so that you have better bandwidth to present your slides. Muskan, are you there? We can see you online, but then have you joined back?
She's not there.
You want me to take you through some of the slides till she joins back?
We'll wait for a minute, I think, more, and then we can just.
All right, sounds good. So she's perhaps not yet joined. So I'll
Yeah.
my screen, right?
Yes, sir. Vaishal sir, can we let Sunny sir present till she's.
Yeah, I think that would be a better idea because we have to keep the time frame in mind also.
That's right. So you're able to see, right, my screen?
Yes, sir. It's visible.
Okay. So, we're talking about statins and, where we stand in terms of glaucoma and what do we know about statins and glaucoma, right? We know, she was already telling us about that, statins perhaps are the first line treatment for reduction of LDL cholesterol levels and, predominantly used for cardiovascular disease and death. What do we know about statins and the eye? There are some studies which have been done. A lot of them have been in animal studies. Of course, there is not much on human direct relationships, but statins are suggested to improve retinal and choroidal blood flow, protect retinal ganglion cells, and lower IOP. And therefore, and also have a neuroprotective action. Somehow, statins, like I said, even in the introduction, is that statins actually might tend to reduce the risk of glaucoma. And that is what we would expect most studies to show us that. And so HMG-CoA reductase catalyzes a lot of steps which can help in reduction in the endogenous cholesterol synthesis. Dietary cholesterol is not always affected, but overall, the cholesterol levels do drop. What do we know about statins and glaucoma? So a lot of previous studies have been done, and almost all of them have shown no association or just a partial association, which is protective. So one of the largest studies is the Groningen longitudinal study, which found no association between statins and glaucoma progression. And a Canadian study, which was actually a population-based study, where you actually go to the population and do that study, found no significant difference in IOP lowering medication used between the statin users and the non-statin users. Right. So overall, what we know so far is that statins don't really influence, glaucoma in terms of, its onset, increasing risk, or IOP, lowering medications, and all of that. Right. So, so then if this is expected, then why do we do this study? Right. So the authors really say that the prevalence of glaucoma is noted to increase with age, and that, age is, of course, the strongest risk factor for glaucoma, nerve fiber layer atrophy, also the strongest risk factor for cardiovascular disease. And given this importance of age, so how does age influence the relationship between statin use and glaucoma? Right? That is basically what the whole premise was, that we know that statins perhaps don't influence much of glaucoma, but when you add age to this whole, crux or complex, how does it change? So if you, figure in age into this whole formula, does statin use change anything about glaucoma is what the study was all about. So the aim of the study really was to investigate association between statin use and glaucoma between 27 and 2022 using this All of Us research program. So this was the methodology where the source of the data was this All of Us research program database, right? So this is a database where, data is getting stored, like a lot of our data is getting stored in our hospitals, in our EHRs and EMRs. So this is not really a population-based study, right? So this is a database which is being used. And who were studied were 79,742 adults who were more than 40 years of age and were hyperlipidemic. So all of them had hyperlipidemia or dyslipidemia of some form. And the analysis technique was using multivariable logistic regression analysis, where we are looking at the outcome as a binomial or a categorical variable. And here the variable of interest, of course, is glaucoma. That is yes or no. Did they have glaucoma or no glaucoma? Right. So what is this All of Us database? So it is an initiative by the National Institutes of Health in the US, right? It began in May 2018 and enrolls participants from 18 years older, that's all older individuals. And there are 340 recruitment sites all across the US. And it uses health questionnaires, EHR data, physical measurements, digital health technology. A lot of specimens are also collected, and it strives to have advanced precision diagnosis, prevention, and treatment. So in the past, a lot of these data were collected under the Enhance, under the Enhanced database, and AOU is actually doing slightly better in terms of collecting data now. Researchers retrieve EHR data through the data browser using keywords related to diagnosis, procedures, and medications. So you can actually go, if you're authorized, you can go into the database and pull out people's diagnosis, the procedures they have had, and the medications they are on at that current time. And for purposes of the study, hyperlipidemia, glaucoma status, and cholesterol medication, as well as beta blocker use, were defined by diagnosis and medication, right? So there's either diagnosis or procedures or medication. So for this, there are no procedures, but medications were, extracted based on whether they were taking beta blockers or cholesterol medications, and of course, glaucoma medications, and as well as the diagnosis was hyperlipidemia and glaucoma status, right? So what they were really trying to find is which factors can actually cause glaucoma. So we call these covariates, right? So they classified covariates into two types. One is continuous, that is the age, body mass index, and LDL levels. The premise being advancing age increases risk of glaucoma, advancing or higher BMI increases glaucoma, and advancing LDL cholesterol levels increases risk of glaucoma. And categorical variables for all of these that you can see, it's sex, race and ethnicity, education levels, income, history of cigarette smoking, beta blockers, diabetes, cardiovascular disease, and macular degeneration. So how did glaucoma change with each of these is what they were trying to study, right? So the design was, this was a cross-sectional study, that is a one-time sort of cut of the data to see whether somebody has hyperlipidemia as well as glaucoma. It was, of course, the data was getting collected on its own. So this was in hindsight, right? So it is not a real-time study it's not a real-time data collection for the study, but looking back at the database. So this is a really retrospective study. And this was, the authors say population-based. That's because, what we are looking at is the whole population data. But, population-based studies really mean, like the Chennai study, where you actually go to the people and, go to houses and visit. So that is really a population-based study. This isn't exactly a population-based study, but also not exactly a hospital-based study. So the primary outcome here was any glaucoma, right? Defined by the International Classification of Disease and all of these. So, they did not differentiate between any of these. If it's open angle or angle closure or secondary glaucoma or developmental glaucoma, all of these glaucomas were, so these are all the ICD codings. And if any of these were present, they said there is glaucoma, right? And the reason they gave for not subclassifying these is because they wanted a relatively large pool of patients with glaucoma, right? So if you have like 30 or 40 patients of glaucoma, you will not really be able to find a lot of covariates which cause this disease. So, they pooled all of these together. So when you look at all of these, so I think Muskan is back. Do you want us to take through? I'll stop my share and then you can actually take us through the slides for the results, if you're okay with that, right? Is your connection all right?
Sorry,
Or do
I
you want me to
connected.
continue?
I'm very sorry. I didn't even know when I got disconnected. I was
No issue.
presenting and I think I got
Do you want me to
disconnected.
continue or do you want to actually present or do you want me
No,
to?
Muskan,
sir,
is your connection
whatever.
stable right now? Do you have a good internet speed?
I have now connected phone so that it does not get disconnect in between now.
One suggestion, Sabayaji, you just play the slide, she'll present.
Oh, yeah. I've stopped my share, and then you can go ahead and share your
Oh, no,
screen.
no. What sir is saying is that you can play it from your end, sir. Sen Gupta sir, and she will present it
Okay.
so that, in case she goes off in the
Do
middle,
that.
then we can just continue.
Okay.
Yes.
So, all right. So you can go ahead, Muskan. I'll go to the next slide.
Okay, so we have reached to the results of the study. So before directly jumping into the results of the study, as we are talking about statins, so we saw that of all the participants that were taken in the study, that was 79,000 almost patients, there were only 8% of patients, like 6,365, which actually were on statins in comparison to the other patients who were not on statin. And if as the comparing group is obviously glaucoma, so we saw that almost similar number of patients were actually having glaucoma, that is nearly to 6,418, and it almost came the same percentage. If we move to the next slide, we can see that if we compare like the main variables, like the cholesterol medication use, the patients who were on cholesterol medications actually, out of them almost 11% patients did have glaucoma, whereas only there was around 8% patients that did not have glaucoma. And it can also be seen in the it can also be seen in the age group that the patients who were on the higher side of the age group, they were affected with glaucoma, whereas the patients who were on the lower side of the age group, like 65 or 66 age, they did not have glaucoma, although it was just a 5 unit gap, but it was still significant. And then the patients that had glaucoma actually had lower body mass index, which is a little contrary, but it was still seen in this study. And but the LDL cholesterol levels did match that patients who were having glaucoma had higher this low density lipoprotein cholesterol in comparison to the patients who did not. The difference is very less. It is almost just 4 milligram per deciliter difference, but it was still seen. And similar trends were seen with the history of diabetes and history of cardiovascular disease. Now, if we move on to the how the results were seen or compared, so there were basically some multivariable models that were taken into consideration. There are total 5 multivariable models through which the results were shown. The first or the foremost main model, which took statins and all the covariates that I mentioned, like Sir mentioned before. The second model was the second model took statins, LDL cholesterol as a continuous variable, and all the other covariates along with it. Then model 1B took statins with LDL cholesterol as a categorical variable, where 5 categories of LDL cholesterol were defined. Model 2A took statins with age as a continuous variable and all the covariates, and model 2B took statins, age as a categorical variable. Again, the age was divided into 5 categories and all the other covariates. Now, first we will talk about the main model, which is statins and all covariates on glaucoma. So, it through this main model, we saw the direct association between statins, glaucoma, taking all the covariates into the consideration. The main being the age and LDL cholesterol, but the rest of all the covariates that we mentioned before in the previous slide were taken into consideration. Here, if we represent it in a form of adjusted odds ratio, it was seen almost 13% higher risk in the statin users as compared to statin non-users, and it is also proved by the 95 confidence interval that the risk is actually significant. So from here also we can see that actually the statin users have higher risk in comparison to the non-users. Now, if we move on to the second model, which is statins, LDL cholesterol as a continuous variable and all the covariates. When LDL cholesterol was taken as per milligram per deciliter increase, so we are taking it as in a continuous manner. There was almost 0.03% higher risk that was noted in comparison to the non-users, and it, as seen by the confidence interval, it is also significant. Now, if we take the LDL cholesterol level uh, as a categorical variable, the first of all, it was divided into 5 categories, that is optimal, near optimal, borderline, high and very high, on the basis of the on the basis of this 100 less than 100 was taken as optimal, and more than 190 was taken as high. So here, if we see, if we go through what the logic says, or what we have already seen in the previous patterns, as the LDL level increases, the risk of glaucoma should increase. That is what comes into the mind. But in this study, it was seen that the patients who had optimal levels of LDL cholesterol and who had high level of LDL cholesterol from 160 to 189 milligram per deciliter, only those patients had actually significant risk, like 39% higher risk was seen in optimal LDL cholesterol level patients, and almost 37% higher risk was seen in patients with high LDL cholesterol levels. And through the confidence interval, we can see only these two are actually significant, whereas in near optimal, borderline high or very high, the risk was present, but they were not significant as seen by the confidence interval. It is also represented in a form of a forest plot, where we can see only the high and the optimal levels are beyond beyond one, like the one covariate, sorry, the one line. So that is why they are the one which are actually significant, whereas all the others are crossing the one or on the borderline. So that is why they are not significant. Now, moving on to the next variable that we take, the next variable we took was age. So, statins in comparison to age as a continuous variable, age with per year increase saw 6% higher risk, and it was also significant as seen by the confidence interval. Now, when we took age in as a categorical variable, we again divided age into 5 categories. So we divided according to decade. So 40 to 49, 50 to 59, 60 to 69, 70 to 79, and 80 to 89. Um, we saw only the age group from 60 to 69 actually had 20% higher risk, and it was the only one that was significant. The rest other age groups were not significant. Even it did not, even in this also, it had the same problem, that it did not follow any trend. As the age was increasing, according to the theory, the risk should increase, but as seen here, the risk did not increase, or it did not correlate actually with each other. So it is also represented in the form of forest plot, and here also we can see that only the age group of 60 to 69 shows significant change, or statistically significant, as compared to the other age groups. So if we come into discussion, this study does prove somewhere that statin use increases the risk of glaucoma, but does not depend on the LDL cholesterol levels or age. So LDL cholesterol levels and age, they do increase the risk of glaucoma, but they are not dose dependent, because no such relationship or no such trend was followed or found. Apart from these two, diabetes and beta blocker use was also one of the factors that influence glaucoma. Now, if we talk about, like, not only this study, there are some other studies that were also done. So the association between statins and glaucoma was also studied. So this study identified association between increased serum LDL cholesterol and a small but increased likelihood of glaucoma was seen. Similarly, in a Singaporean population-based study, Jagannathan et al. Found that individuals with peripheral arterial disease were more likely to have glaucoma or glaucomatous changes as compared to others. And Majeti et al. Found that higher serum total cholesterol, high density lipoprotein cholesterol, and LDL cholesterol were associated with higher IOP. And a meta-analysis was also done. 1 minute, I think I can't see your screen.
Are you not able to see my screen?
Can you go on the previous slide, please?
If you go press association.
Just 1 minute, I have some water.
We are on the equivocal association slide.
Now, if we now these were the studies that were done that showed association from the point of view that statin does influence the prevalence of glaucoma. But there were other studies which showed no association or equivocal association between statin use and glaucoma. So one such study was Wang et al., which found no significant difference in serum lipid levels between participants with versus without glaucoma. A meta-analysis by Posh, Pert et al. Also showed like no similar changes or anything that was happening with a higher total cholesterol or higher HDL cholesterol levels or and its association with glaucoma. Similar studies were also done, and these conflicting findings suggest that we should actually study more or should research more that whether it is actually the levels of like the cholesterol medications or the level of cholesterol that is impacting the glaucoma. Now, the contrary part that actually came was that there are some studies that actually prove that statins, instead of causing glaucoma, they are actually like protecting the individual from glaucoma. So, one such study was 10 et al. Queried US healthcare claims in which 5,24,109 patients with hyperlipidemia from age group 60 years were found that as the period of statin use increases, there is actually a lower risk of glaucoma. So, if the patient has taken statins for 1 year, there is almost 4% lower risk of glaucoma, and for in 2 years period, the reduced risk almost doubles, means almost 8% more protective action is seen in that individual if if there is prolonged action of statin. So, and then there was one study, Talwar et al., that also showed that actually statin lowers the risk of glaucoma if the patient is taking the medication. And one such study was also done by McQueen et al., who found a significant association between statin use and decreased glaucoma risk. Now, on concluding the whole study, statin use does like this. According to this study, statin use is associated with higher likelihood of glaucoma in adults with hyperlipidemia. The association was seen in individuals with optimal or high LDL cholesterol levels and those belonging to the age group of 60 to 69. But as mentioned earlier, these are not dose dependent, and this finding suggests that statin use may be an independent risk factor for glaucoma, and it may not be associated with other variables that we took into the study. But still, because there are so many factors that are not yet very clearly defined, it does need further investigations. Now, the strength of this study was definitely its larger sample size, because of this large sample size, every variable that we took did give us a statistically significant value. Then the second thing was involvement of the recruitment sites and network partners through the US, because we got such a huge data from there. And additionally, the participants, if we saw, were actually the participants who are usually underreported at that time, because most of them were black patients as compared to the white patients. Now, there are some pitfalls that is seen in this study. So, as we saw previously, some studies found that prolonged use of statins actually decrease the risk of glaucoma. So, this study could not clearly decline that factor, that no, that the previous studies were wrong or something, because this study also not clearly could tell that it was statins that was affecting the glaucoma risk and not the LDL. Because if the highlighted parts, if you can see, I have taken them directly from the study, and the study is actually trying to implicate or shift or deflect onto the levels of LDL cholesterol more as compared to statin, and it is somewhere also trying to blame the genes and molecular makeup, which is nowhere to be mentioned, like in the primary outcomes and everything. So these were some things that that does make this study a little non-reliable in comparison to the other studies.
All right. Thank you so much, Muskan. I just stopped the share. Thank you. It was quite a complex paper to go through, and with a lot of different multivariable models coming into the picture. We will try and break them up a little bit as we go along. First, I would like to invite Dr. Ramalu to have his initial impressions on the paper, and what are the key takeaways, and where can you place this in the existing jigsaw of knowledge between statins and glaucoma.
Thank you, Dr. Singupta. You really we're so proud of all that you've accomplished. You were with me for a year, but you've gone on to do many things that that I didn't teach you how to do, and your dedication and hard work are really impressive. And Dr. Muskan, that was a very nice presentation. So thank you for kind of introducing the article to us so that we can think about what it means for our patients. So, whenever you try and break down a paper, I like to look at three things. What is the exposure variable? In other words, the independent variable. So in this case, that's statin use or cholesterol level. What is the outcome? In this case, that's glaucoma. And then, who is the population that's being studied? So I think we can look at all three of those things. And there's some caveats that we have to take from all three of those. So let's start with the population that's being studied. So first of all, these are just people who are, had a code for hyperlipidemia. So, you can't really assume anything other than, we're only talking about the hyperlipidemics. And of course, that's really the only group that would really be put on a statin in the first place. I think the second thing you should think about is, what type of population is this that really even enrolled for this all of us study? So, they make a comment in the discussion where that 8% of individuals that Dr. Muskan mentioned also, were on a statin. But actually, if you look at the population of people in the United States, it's 28%. So it's actually like less than 1/3. So this is a much healthier population than normal. And in fact, people had to opt in to be in the study, and they had to be willing to share their genetic data because they would be told if they have some genetic predisposition to a disease. So these are people who are like very health seeking, very healthy. They're like Dr. Sengupta who lost all these kgs of weight, with exercise. So that's, these are the people who, it's enriched for people like that, in the study. And so, you can't necessarily generalize it as much as maybe you would like within the population. The next question is, what is the outcome? And I think you made had a nice slide which showed that it's really all glaucoma diagnoses. But even then, I think you have to question that a little bit because, they found that, as you showed in your slides, that 8% of individuals, had a diagnosis of glaucoma, but 8% of people don't have glaucoma. Even in this group of 66 plus, you have to get into like the 80 plus very high risk, races to really get 8% prevalence of glaucoma. And of course, most glaucoma is open angle glaucoma, as and at least in this kind of population. So I think Dr. George has done some beautiful prevalence studies. So he'll tell you that 8% is really kind of outrageous to get as a prevalence. So probably a lot of these people have ocular hypertension or narrow angles or just glaucoma suspects or something like that. So not all of this is really glaucoma. The other thing I always worry about with these kind of studies, which the authors did a pretty good job with actually, is ascertainment bias. So how do you know they didn't actually examine all these people to say whether they had glaucoma or not? They're relying on whether somebody else examined them and saw them. So is it that if you get a healthcare seeking population, you're going to get more diagnosed glaucoma because those people are going to the doctor more. So here they did a pretty good job actually, that they actually looked at the frequency that, they just asked them a question, have you seen ophthalmologists in the last year? And they found pretty similar percentages, across the variables they looked across. So probably at least that this may not be a reason for, for what their findings are. The final thing is that, is really, statin use, the exposure over here or not? And I would make the argument that it's really, it's not statin use, but it's really the decision to treat people or not. First of all, almost everybody who gets treated, so they said 98% of people who are on a cholesterol medication were on a statin. So, when you say statin use, it's really the decision to treat somebody that you're seeing as the exposure variable or the independent variable over here. And then you also have to ask, like, okay, well, why do you decide to treat somebody with a statin or a cholesterol medication? It's usually based on their risk profile. So, they're going to have, higher LDL. They're going to have other variables. There's groups that you treat regardless of their LDL level. So if somebody had a previous heart attack or stroke, or has a very strong family history, or if they have other variables, which may still have some residual confounding beyond the models they did. So in other words, if they if they adjusted for diabetes, but what if they're a very poorly controlled diabetic? If they have cardiovascular disease, so if they have, known stenosis of their cardiac arteries, these are the people who are going to be more likely to get treated. So, when you say statin use increases your risk, is it the statin use? Or is it the reason that somebody would get treated with the statin that is actually the risk? And it may well be that, people who are unhealthy, who, have a sedentary lifestyle, have poorly controlled diabetes, have a strong family history, have already had had an MI or a stroke, that these are the ones who get treated with a statin preferentially. And these are the people who are just generally more sick. So, it's not surprising that they would develop a lot of different diseases. And they can't really account for all these things. I think the other thing that's pretty interesting is that if you look at like what the comparison population is, it was the people who weren't treated, but still had a diagnosis of hyperlipidemia. But in fact, those people weren't hyperlipidemic. So, if you look at like their LDL levels, it was 136. So technically 160 is high. So 136 is like borderline. I mean, I guess borderline may be enough to treat them. But then actually it's not actually even that high. So, you're getting people who didn't even really have this problem in the first place. And so kind of, paradoxically, they found that the LDL level in the people who were treated with the cholesterol medication was actually higher than the people who weren't treated with the medication. So, how can that be? So these people probably had very high cholesterol, and that's why they started to get treated. So, so for me, I mean, I don't really put this on the statin, I mean, I kind of, take it to mean that, people who have, very high, risk of disease, cardiovascular disease and cerebrovascular disease, who people are, choosing to put, on a statin, the doctors are choosing to put on a statin, have a higher risk, and then the LDL finding may be just kind of some residual confounding that, that these people started especially high and, you couldn't get them low enough. And so that, these are the people who are actually at higher risk. So I think it probably, speaks a little bit to, so I think it is saying something, but it's not necessarily saying something about the specific medication. It's probably saying that, kind of poor cardiovascular function and, poor metabolic health is probably contributing, to your risk of glaucoma to some extent. And there's a variety of evidence for that. So, this is what the paper says to me. I mean, how does it really change how we behave and how we make recommendations to people? I mean, it probably says that you should keep yourself healthy. I mean, I would never tell anybody not to be on a statin. I think the people who are on a statin had to be on a statin because probably their cholesterol was much higher. So I would encourage them to, get, statin treatment by their doctors. I would definitely not tell them that they should be off of it. I would tell them that they should probably, keep their cardiovascular health good in other ways, reducing their stress by other things that have been suggested to be helpful with, with glaucoma, such as exercise and meditation. So, I think it's just a matter of them keeping themselves healthy. But, the take home for this definitely should not be that, people should not use statins. I think that's the wrong conclusion.
Thank you so much, Pradeep. And I think you really, laid threadbare as to what the actual conclusions should be, and that we perhaps are, blaming statins without much evidence from this paper. So I would like to invite Dr. Ronnie George for his comments on, or your initial impressions on, what you thought of the study and, where we can employ it in our clinics.
Thank you, Sabyasachi, and thank you, Dr. Muskan, for nicely dissected paper. So I agree with all of what Pradeep said. And the first thing that strikes you when you look at this paper is, if you look at the first table where you're looking at the patients with glaucoma versus the ones who don't have glaucoma. The patients with glaucoma were on an average about 5 years older. They were also less likely to be non-Hispanic white. The substantial population was either African American or Asians, both of who have more glaucoma. They were less likely to have less education, less income, slightly higher LDL, and significantly higher beta blocker use by 10%. So beta blockers are typically nowadays not considered first-line medications for hypertension. So that would suggest that maybe these were second-line medications or given for a cardiovascular reason, which means they had more difficult to control systemic disease. They had 14% more diabetes. And that's, again, one of the risks, one of the indications to give a statin in many patients. Once you have diabetes with any other hypertension, many physicians prefer to give statins just off the top of the head, and a little bit more AMD. So when you're looking at a slightly older, sicker population, it is sometimes difficult to correct for all variables, especially considering that this was a voluntary study and everybody's physicians would have treated them as per whichever way they wanted. It's again, when you look at the age, that 60 to 69 peak that they see, I find that a little unusual, because when you look at the data for each age group, you're not seeing a steady progression. We're actually seeing a U-shaped curve. And that's pretty unusual to see with a disease, with both diseases, your cholesterol goes up with age. Glaucoma goes up with age. Why do you see this U-shaped sort of curve? So I'm just wondering whether there's some confounder that we are missing. If you look at the other material on the subject, the couple of 2-3 meta-analyses that have been done, one more confounder comes into the picture, because these studies have been done from across the world, so you have studies done and across time points. So one interesting thing with cholesterol levels have been that thresholds for treating hyperlipidemia have been dropping over the past 15 years or 20 years. We went from saying that, 250 is okay, to now saying that we should treat 150. And also across Europe and the US, definitely you have differences in the way that people address this issue. And that might account for some of the reasons for the differences that you see across studies. But the 2 most recent meta-analyses really did not find any association between statin use and glaucoma. So one of the challenges, as Dr. Pradeep was saying, is that it's difficult to draw inferences from a study which looks at associations. So papers which look at association don't necessarily talk of causations. There are multiple reasons why these may be associated, and with such large numbers and such varied examination criteria, I think that's always a challenge. Keep in mind that the oldest age group had almost 15 to 20% glaucoma, which we don't see in any population. So yeah, that's more or less what I have to say on the study.
Yeah, thank you so much, Dr. George. Yeah, very insightful. I'll come back to Dr. Pradeep. So Pradeep, do you look at LDL levels in your glaucoma patients? And I'm directing the question to both of you. Do you really look at it? There's so much to look at, isn't it? So many systemic factors, so many ocular factors to look at. So do you really look at their cholesterol levels, and you ask them to get their cholesterol levels on a periodic basis? If yes, you perhaps will say no, but how do you fit all of this into the diagnostic and therapeutic algorithm that's happening in your heads in terms of LDL? So do you really look at this level? And if yes, how do you fit it into decision making, and do you?
Yeah, I think it's a good question. And this comes up a lot with hypertension too, because people have suggested that, we shouldn't use, especially nighttime antihypertensive medications in the setting of glaucoma. I mean, first of all, I think that we are eye doctors, but, we can't really lose sight of the big picture, that people have other conditions and there's other experts who are taking care of them in these conditions. And I'm always very, hesitant, unless I think I can, simultaneously improve their glaucoma health and their general health, to really step into those areas, So, of course, you want to encourage people to be healthy, but in this case, I would never tell somebody to withhold the treatment, for example. And even, with the other one that's brought up a lot, nighttime antihypertensive medications. One of my colleagues, his wife is an internist, and she said that the nighttime diastolic blood pressure is the strongest predictor of stroke risk. So the parameter that we think is, increasing the risk of glaucoma is actually the most protective against a very important, cerebrovascular event. So then, do I really want to tell people, oh, no, don't do this? Because, well, it may have real implications on their general health. So, I mean, if you feel very strongly that, you're going to change your decision-making based on this, you can consider it in, a very small number of cases. But for the most part, I'm trying to look for the synergies. What can you do that, can tell people to be more physically active and exercise, or if they can't exercise, at least walk and do some meditation. Things that are going to kind of, be a win-win, improve their glaucoma health and also improve their general health as well. And I'm usually very reluctant to, step into somebody's general health unless there's a very specific reason to do so.
Dr. Ronnie, do you look at LDL levels and do you at all consider them in your routine decision making?
Well, I definitely ask them about their systemic health. I really would not go into the nitty-gritty of their LDL levels because that's not my area of expertise. But if it looks high, then I would definitely ask them to speak to the internist, because it doesn't make sense for me to step into somebody else's preserve, just like Dr. Pradeep was saying. And there are so many interactions between, and nowadays when you get patients coming to see you, you sometimes see them with a list of 12 medications and 150 blood tests. There's nothing much that I can, as an ophthalmologist, advise them beyond taking care of their health and, seeing whoever they need to see. And the evidence, at least in this paper, or in most of the papers on statins, is so insubstantial that I don't think it would make a difference to my patients on a whole. It might make a difference to one or two patients, but not to the whole lot.
Right. I think Pradeep brought in
the only thing I may change, Sunny, for this, and Ronnie, is that, there's a few people here in the US who have, grants to, kind of do, use natural language processing and kind of extract out all this information and then use, AI or, machine learning to kind of, stratify somebody's risk, looking at patterns of things. So, and is it possible that everything about the person, that you can judge from their medical record could be useful? I believe that. But, as kind of individuals, as people saying like, oh, I'm going to pick this out and do something about it or pick something else like that, I don't think that we could do it or should do it. Is it possible that a machine could do it and kind of ascertain somebody's risk? That remains to be seen, but, people are working on it, and there may come a day where it can, it can analyze what Ronnie is saying, this, metabolomic profile or, inflammatory profile or some list of 200, blood parameters, and say, okay, you should be more aggressive or less aggressive with this person. But, that day is not here yet. So for the meantime, I don't know that there's much to do.
I think with all these questions, and I'm very keen to see one table which talks about statin versus no statin. They talk about glaucoma versus no glaucoma, but it would also have been useful to provide a table where they looked at statin versus no statin, and then we would realize that these are perhaps the more sicker people, and so that is kind of perhaps a table which they haven't provided and might have done well to do. So sort of the take-home message is that don't ask your glaucoma patients to stop their statins, because statins, this study doesn't really tell us that, statins will cause increased risk of glaucoma, right? So I don't think any of us are going to now tell our patients, oh, you are on statins, please stop it because your glaucoma is going to worsen and things like that. So Pradeep, one last question I had for you is, do you want to comment on, on the treatment effect where they say it's, 13% higher risk? And, does it matter whether it's, it's a relatively small risk, even if it's statistically significant. So, would it matter if it was like an 80% higher risk or like a 3 times higher risk versus? So can you shed a little bit on how you interpret this treatment effect? Because, sometimes very large sample sizes will cause anything to become statistically significant. So do you, so what we are talking about for all of you listening is that, the odds ratio tells us that the risk is higher because it's more than 1. Now, how much higher is also what it tells us. If it's 13%, 1.13, that means it's 13% higher risk. If it's a 1.60 odds ratio, that's a 60% higher risk. So we are looking at the number after the decimal. And if it's more than 1.9, we call it 2 times higher risk, 2.5 or 3 times higher risk. And that is the treatment effect, right? So I'm just asking, how do we interpret that in terms of these studies? So is 13% too small and then like 40% too high? Is there anything that you look at in terms of treatment effect?
Yeah, I know that's very important, Sunny. And I think, Dr. George mentioned that, in these kind of studies, you just worry about some, unmeasured confounder, you know. So when you're so close to one already, you know, all it takes is like a little bit of, you know, residual confounding or unmeasured confounding, and then all of a sudden you have it, you know. And as you measure, you know, as you mentioned, I mean, we never really know what the risk is, but once you start getting to 1.5, 2, things like that, you don't see these strengths of association very often. So you say, okay, you know, even if there was some confounder which they didn't measure, then this, you know, this is a pretty strong effect. So it's going to take a lot to, you know, to drive it down to, you know, to a non-association. So, you know, so I think we definitely should look at it. And when we see these small effects, you know, especially from these huge data sets, you know, there's a lot of things that that could cause it, you know, and you know, you have to take the authors at their word that, you know, they started off and decided to look at statins because they had an a priori hypothesis. Honestly, you know, I think Dr. Muskan reviewed the literature really well, and there's not really a lot of literature to say that like, oh, this is the one thing I would have looked at, you know, and then you always worry like, how many things did they look at, you know, to find this one association? So, you know, I think we often think of like, okay, there's, you know, the experimental association. But if they said like, oh, let's look at a, you know, bunch of medications and everything else, and I'm not saying they did this, I think there's a very good group and did that. But, you know, and sometimes people, you know, say, oh, let's investigate 4 or 5 things, and then one of them turns up positive. Then, you know, in the real life, you should actually do what genetic studies do, you know, where they, you know, they have a, you know, Bonferroni correction. So they say, oh yeah, we looked at these 5 different exposures, so we should, you know, cut down, you know, and we should adjust for that. And so that's the other, you know, little concern I have from these large studies, that it's so easy to look at so many different exposures that you're going to find a few things just by chance. So unless you do it in a systematic way and really look at all of them and say, yeah, this is how we chose these things. So you had very good hypothesis driven research, and you say, this is why we looked at this specific thing and not something else. Then it also worries me that, like, you know, it could be a false association just based on the number of things they looked at.
Right. Dr. Ronnie, one question for you is this: do you think this is like the right study design to answer this study question? Because this is like a cross section, right? This is just one. You know, the effect of time has not been studied. So how long after statin use does increase glaucoma risk increase, or you know, so all of those have not been taken into consideration. So do we think that these kind of studies, or a lot of these enhanced database studies, which are like one-time cross sections, are good enough to answer these study questions? So your take on that,
Yeah.
and then you can.
So very briefly, they're not the ideal design to look at this. You would ideally do a cohort study and really look to see whether there's causality. But sometimes if you see a really large effect, you might actually pick up something which would otherwise not have been missed. And again, whenever I'm looking at the effect, I also want to see how tight the confidence intervals are. If the confidence intervals are very tight, then I give that a little bit more credit than a wider confidence interval. So definitely this is not the ideal design for the reasons that you just mentioned. But unfortunately, to do it with an ideal design, you'll take 10 years to get your results, and
Right.
sizable $1 million down, I mean, few $1 million down the drain.
Right. Pradeep, your take on the time factor that we are not looking at in this study. Pradeep, are you around, or?
Oh, sorry, yeah, sorry. Well, you said the time factor, and
So how long after statin use does risk of glaucoma increase, or for that matter decrease? And you know, these are things which have not been looked at in this cross-sectional study. So your take on the study design per se, and you know, if this is not the right design, then what would be the right design?
yeah, I mean, there's many, you know, database studies that have, you know, looked at, you know, they have a run-in period to make sure that you didn't have a glaucoma diagnosis. And then, you know, and you can also have a run-in period to make sure you're not hypercholesterolemic, you know, or hyperlipidemic. And then you can look at incidence and all of that. And there are, and I think, you know, some of those studies that have looked at that, you know, were quoted by Dr. Muskan and reviewed by Dr. Muskan. So, you know, that's another way to look at it, and that gives you a little bit more confidence. I mean, it's still, you know, and it's really difficult to know, because what are you going to do, you know? You know, the gold standard for knowing something is a randomized trial. So you get rid of all the confounding completely. But then, you know, unless another treatment comes along, you know, whereby you, you know, where it has similar effects and, you know, health benefits to statins, and you can randomize somebody to a statin or a non-statin, and then maybe kind of, you know, append, you know, an ophthalmic study, you know, to that study. So you can look at kind of, you know, ocular health and glaucoma as a result of that. You're going to have a very hard time, deciding whether this is really the cause or not, or whether it's just the underlying condition or some unmeasured confounder. So I think we're in a pickle, with that. It's really hard to know. So sometimes this is the best we can do, although I think we could have done a little bit better, by looking at some of these longitudinal data sets. Some of that work has already been done.
So if these relationships were dose dependent, where the increasing cholesterol levels would have a higher and higher treatment effect, and similarly, if you look at age, and those numbers would be slightly different, where it was a uniformly increasing treatment effect. Would you now consider statins to be more of a, because currently we don't have a dose dependent response, right? So, but if there was one, would you think statins would then be looked at more as a causality? Or do you think, I mean, the real question is that, do you really put a lot of credentials on this dose-dependent relationship for causality?
I mean, that's hard to tell because, even here in these kind of analysis, I mean, it depends on what you consider the dose. I mean, if you consider the dose of statin, the higher dose is used for people who are at higher risk, right? Because they have a greater need for more aggressive, LDL lowering. So, so does it, even if you saw, a greater benefit with a higher dose of statin, does that mean that you're seeing a greater or, a higher risk? So is that because they have a higher, the more medication is causing them more damage, or is it because they actually had more cardiovascular disease or a higher risk of future cardiovascular disease? And then so then it's not the statin itself, it's the higher risk of cardiovascular disease or the higher prevalent cardiovascular disease. So even then you couldn't really say it. And then of course it's even more complicated because there's different statins and what's the relative efficacy and how do you really account for all that?
So I think it's been a great discussion, and what I understand from this discussion is that such kind of studies are not very ideal to infer and associate things with, and a proper ideal study design would be a better study. So because time is running out and we are almost short 10 minutes above time, and I would ask Sabyasachi Sengupta to ask the faculty to give their concluding remarks.
Right. Thank you so much, Dr. Vaishal. And Pradeep, your final take on, would you really take this paper to clinics? Yes or no, and pretty quickly, why?
No, I mean, I think that, I would only just take it as a measure that, people who are requiring other treatment and who are generally sicker, maybe at more risk for disease, and I would leave it at that. But I just wanted to congratulate, Dr. Sengupta and others for putting this together, and also to thank everybody who has the dedication to come in the evening and listen and learn something and, better themselves as well. So, we appreciate you.
In fact, we appreciate you for sparing time for us from USA, from your busy schedule, and really appreciate that. You could find time for us and discuss for a journal club meeting. It means a lot to us.
Thank you so much. Dr. Rani, one final comment on whether you would actually take this to clinic, and if yes or if no, and why?
No, I probably would not take it to the clinic because I don't think the evidence is strong enough. And again, the consequences of stopping a statin are much worse than the consequences of having a slightly progressing glaucoma.
Right.
Because of this.
Right.
So I think that's, for me, that's what's important.
Yeah, so I think that was a important bottom line that, it doesn't change much to what we are doing today. So thank you so much, everyone, for attending this session. And like Dr. Vaishal said, we are slightly over time. And, most importantly, thank you to Dr. Muskan for, bringing this quite difficult paper to light and, presenting it in a very simplified manner for all of us to understand things. So thank you so much, everyone. And Dr. Vaishal.
Before we conclude, I would ask the MOS president, he wanted to make an appeal to every one of us. Sir, please go on.
Thank you, Vaishal bhai. As you know, the election of AIOS is going on, and our own MOS member and our own MOS past president and advisor, Dr. Lane sir, is contesting for a post of the VP elections. It's my earnest request to all of our members to work hand in hand to take him at the aim of the society. Please vote for him in large numbers. Thank you.
So I asked Dr. Piyush Bansal to give a vote of thanks.
Thanks, Dr. Vaishal. First of all, I'd like to say excellently presented, dissected out, and prepared, Dr. Muskan. To you, congratulations, and to your mentors as well. Next would be, of course, sparing so much time, midweek morning, Dr. Ramulu, and I'm so sorry about that. Midweek morning, Dr. Ramulu, and midweek evening, Professor George, for not only dissecting, also the best people to dissect out most papers are the nerve and pressure guys. And this was no different. So thank you so much for not only dissecting out and telling us your, your excerpts on the paper, but also your practical and clinical experiences. But most of all, I would like to thank our young brigade, Dr. Zain Khatib, Dr. Neeraj Israni, who were wonderfully mentored by Dr. Parul Deshpande, Dr. Vaishal Kinya, and of course, amalgamated and completely shouldered by Dr. Sabyasachi. So this was a wonderful journal club. I immensely learned a lot from it, and a big thank you to everyone from Bombay Ophthalmic Association and Maharashtra Ophthalmic Society.
We thank the Entod Pharmaceuticals for helping us host this Zoom meeting. Thank you so much once again, Dr. Pradeep Ramalu and Professor Ronnie George for coming to this journal club. And thank you, Sabyasachi, for having a beautiful journal club discussion today. Thank you, everyone.
Thank you.
you.
Yeah. All right, then. Bye-bye.
Everyone,
Thank you.
bye-bye.
Thank you so much. Thank you. Thank you, Ronnie George. Thank you so much. All right.